All right, hello everybody. It's Dr. Alex Earle, and we're here at Pure Plastic Surgery today, and it's Hump Day with Dr. Alex Earle. And well, this is a special Hump Day because sadly, it's probably going to be the last Hump Day of 2020. So, you know, after this week, I'm on a little vacation, and so won't be back till 2021. So, you know, exciting and sad at the same time. Last Hump Day of 2020. And kind of like I did last year, I like to wrap up the year pretty much giving you my stats. You know, this is not something that a lot of plastic surgeons will do, but I'm proud. I'm proud of the work that we've done here. I'm proud of my stats, and this is something that I will do on a yearly basis so that you know where I'm at, and you guys can make informed decisions, because at the end of the day, really that's what it's all about. That's why we have Hump Day, you know, throughout the year, why we have informative topics, why we answer all your questions, because we want you guys to be educated. We want you guys to be informed, because that's the way you can make the best decision for you. And hopefully that decision is coming to Pure Plastic Surgery. But no, not necessarily. It's not about that. It's about you guys being, you know, educated, informed, and comfortable in your decision, so that this whole plastic surgery thing just doesn't seem, you know, so scary. Okay? So now when I talk about stats, I typically talk about BBL, because for some reason that's what people ask the most. I don't know if the BBL patients are just a bit more intense, or they're a bit more into information or research, or because it is a surgery that's viewed out there as potentially kind of one of the more, people say one of the more dangerous ones in terms of aesthetic surgery. There's actually a lot of plastic surgeons who don't do it because they just, you know, they don't have the experience with it. Okay, so I'm going to talk about my stats mainly about the BBLs, and so let's kind of go into it here. So, all right, so BBL stats. All right, so what I'm gonna be comparing my stats against those that are basically a congregation of those of, you know, fellow WAG member experts. Okay, what is WAG? WAG is the World Association of Gluteal Surgeons. I'm a member of that society, and there are multiple, you know, world-renowned experts on there. And last year, so December 2019. They gave a talk in which they talked about all the kind of potential complications and issues with the BBL. And so who am I talking about? Well, I wrote the list here because I always don't remember off the top of my head, but these are experts, and you may have heard some of these names, but Dr. Corsandi, Dr. Simeon Wall, Dr. Presmino, Dr. Hoyos, Dr. Mendieta, Dr. Senderoff, Dr. Aslani, Dr. Steinbreck, and Dr. Teitelbaum. We're all on this panel. And so we're talking about numbers from the experts, and we're talking about experts not just in the US, but throughout the world, okay? So in South America, out in Europe, okay, as well. So they gave a panel, they talked about kind of the most important things in regarding potential complications with the BBL, and these are the kind of aggregate numbers that they came up with, okay? So, all right. First, before we do that, you know, how many BBLs did I do last year? I did 562. So my numbers are based on all the BBLs that I did in 2020, which is approximately 562, which brings my total BBL kind of lifetime pretty close to about 2,000 now. Okay, close to that. And so the first thing that they talked about during this panel was the revision rate, okay? So I know we've had a lot of talks here about, you know, the BBL, why it's a surgery that is not, you know, that has more variables than most other surgeries, that is not as predictable, say, as a lot of other surgeries, such as a breast augmentation or a tummy tuck. And I'm not going to go into those details here today, but I've done those talks. You know, you can always look them up on our YouTube channel or on the Pure Plastic Surgery IGTV, where we, you know, discuss why there are so many variables in BBL and why the results are not as predictable. Okay, but so it has, you know, compared to a lot of other surgeries, it has a relatively high revision rate of 10 to 15%. Okay, that is the one, you know, by the expert panel here. And so today I've gone over. So we did 562 BBLs. And this year we did approximately 33 revisions, okay? So about 33 revisions, which brings you a revision rate of about 5 to 6%, okay? So certainly not zero, but definitely about half the revision rate of, basically BBL surgeons throughout the world, okay? The next kind of number that I wanted to talk about is fat retention. So this also varies. Of course, different people have different techniques. Is there one technique that has been proven to be the best? Unfortunately, there has not. Otherwise, we'd all be doing it. One of the nice things about, surgery and actually medicine in general is that when somebody comes up with a really great idea that actually works and is reproducible, then they publish it. And we're all reading all these journals. PRS is one that I like to read. And so if there was something that really, really worked, then we would all be doing it. But unfortunately, there's not one method that has been proven to have the best fat retention in terms of BBL. And so the average fat retention rate was actually 50%, okay? And here at Pure, I believe that my fat retention rate is actually closer to 70%. A lot of you guys have heard me speak, and also, when you come in for your pre-op and we talk about, things to expect, I always quote that, we do expect to lose some of the fat, and we probably, in the average loss is about 30% here at Pure. However, it does vary from patient to patient, okay? So even though, taking all comers, taking, 562 in the year or 2,000 in total, the average loss is about 30%. It doesn't necessarily mean that's what it's going to be for you. Each patient is different, okay? All right, and then also, there is some variability. That's just kind of a global average. I think it does vary a little bit in terms of where. So like in the buttock proper, say kind of central buttock area, I think the loss is actually a little bit less, maybe about 20% or so. And then in the hip area, it's a little bit more. I would say in the hip area, it's about maybe anywhere between 40 to 50%. And the reason for that is because the blood supply to the hip area is not as robust as the one to kind of the central buttock area. So that's the main reason there, okay? All right, so that's fat retention. All right, the next important thing that people always ask about is the infection rate, okay? Once again, we're operating in an area that, A, involves the whole body, so we got to prep the entire body. And B, of course, we're working near, we're working the buttock, or working near the anal region. So of course, there's going to be bacteria present there. And so even though we do everything that we can to try to minimize the risk of infection, it's literally impossible to get it down to 0%. That's just not possible. And it is higher in a BBL than, say, a breast augmentation. So a breast augmentation is a very small incision, say 3 or 4 centimeters max, in what we consider to be a clean area. Whereas a BBL, you're putting in all this fat, 1,000 cc's, 1,500 cc's in an area in the buttock, which is near the anal region. Okay, so that's, that in of itself explains why there's a potential risk for infection when you're dealing with a BBL. And then of course, we as humans, we all carry bacteria on our skin, on our bodies. And unfortunately, one of the ones that's kind of, better known out there that used to be pretty much only present or, certainly more ubiquitous in the hospital setting, is now actually out in the community, and that's Mrsa. So Mrsa is no longer just a hospital acquired bacteria. Mrsa is out in the community, and pretty much anyone can get it. And we do, some people do tend to harbor it in their nose. So a lot of you may ask, like, hey, Dr. Earle, why do you send us this mupirocin, this ointment to put up our nose, 7 days before surgery? That's kind of weird. And the reason is exactly that, because Mrsa is out in the community. Do I know you have it? I don't. But I just kind of allow my patients kind of, put a little of that mupirocin because we tend to harbor it in our nose, and that'll help, decrease the bacterial load. Okay, so overall infection rate, 10 to 15%. 10 to 15%. That's fairly high. But here we're talking about all infections. So anywhere from, say, a minor infection that required, say, more oral antibiotics, to something in the middle, which may require hospitalization and IV antibiotics, to kind of the more severe infections that may require actually a surgical intervention, such as drainage of an abscess or opening of a wound. Okay, so the infection rate here at Pure for 2020 has been 3%. Okay, 3%. So certainly not zero, and I would love the experts here. And we're really, really proud of that. Okay, and why is that? Well, as you guys know, Pure here, we're certified by JACO, which is a Joint Commission, which is basically the highest level of certification that you can get in a office-based surgery setting. And so, we do a lot of extra steps basically in order to comply with them, but of course, really ultimately for the patient, in order to try to, minimize that infection risk as much as possible. So we put a lot of effort into this. In the OR, we do several extra steps to try to minimize that risk as well. For example, prior to after the liposuction is done, prior to doing the fat transfer, the patient's actually prepped once again. The anal area is covered with a lap pad with betadine. We put antibiotic into the container that has the fat. So we put clindamycin and gentamicin into that container, and we prior to the fat transfer, and we wipe the cannula, the fat transfer cannula, before each pass. So before every single pass, we're wiping the cannula with betadine solutions. Okay, so multiple different steps, different things that we do to try to minimize that risk. But and it is frustrating. It's frustrating for me, believe me, and I'm sure it's frustrating, unfortunately, for the patients that got the infections. We can't get it down to 0%. That's just basically physically impossible. But we've gotten pretty low, and we're very happy. We're very proud of that. Okay. And then, of course, the one thing regarding BBL, which most people are always asking about. People always worry about, because if you do this procedure wrong, it could be fatal. Okay, you guys know that. So if you put that cannula too deep, and if you put it basically deep to the muscle, we have those large vessels there, that superior gluteal vein, that inferior gluteal vein, and if those get lacerated and fat gets in there, they're going to get a fat embolus, which is potentially fatal. Okay, so that's the one thing that's talked about a lot. Okay, and before we had a lot of information, it was actually encouraged to put the fat into or below the muscle because for multiple reasons. One, the fat survival rate was better because it has a much better blood supply. Two, it was easier to create those nice round shapes, because it's a lot easier to mold something when you're putting it into or deep to the muscle than when you're trying to kind of reshape something just between that muscle and that skin. Okay, and then also at that time, although it's changed a little bit, but at that time a lot of projection was what patients were asking for, and then of course you were able to put in a lot more fat because you have multiple spaces to put the fat in, right? You can put some fat below the muscle, you can put some fat into the muscle, and then some fat above the muscle. So basically you can think of it as 3 separate spaces where you can add fat. So you can add a ton of fat and get a ton of projection, okay? But nowadays we know that's not the right thing to do. That's not the right thing to do for the patient. That we want to make sure that fat is in the safe plane, in the safe space, and the safe space is between the muscle and the skin. So now you only have one area to put the fat in, okay? But if you're able to do that, and if you know that you're doing that, you know that that those vessels are not in that location, and that the risk of fat embolus is going to go way down. Okay, so as many of you know, one of the extra things that we've done here at Pure is that we use that ultrasound machine, because when I'm about to place the fat into that, what we call the danger zone, I want to make sure that I know where the tip of the cannula is, and I want to make sure that it is above the muscle and in that safe space. Okay, so before we knew, we had all the data, the mortality rate for BBL was 1 in 3,000, pretty high, the highest of any cosmetic procedure by far. Okay. After that, once we knew that this is dangerous, it's not the right thing to do, and we started, doing all the precautions. Not everyone uses ultrasound, but people started, really trying to make sure they know or feel where their cannula is. That's one thing. Then, of course, we started using only blunt tip cannulas. You want it to be at least 4 millimeters or higher, single hole, and you want to be placing the fat as you kind of retract out, and you want the cannula to be in continuous motion. So all these things that we're doing to try to minimize that risk of fat embolus, we've combined some of our numbers from WAGs. Okay, once everyone in that society made the switch to what we call, superficial BBL only, meaning that we're only placing the fat between that muscle and that skin, okay? So once that switch has been made, I can't give you the exact numbers because the study is not out yet, so it's not complete, but I can give you some preliminary numbers. That has dropped way down to a mortality rate of about 1 in 25,000 to 50,000, okay? And that's, okay, but that's with going with WAG's member experts, okay? You want to make sure you're going to the right person. You want to make sure you're going to a board-certified plastic surgeon or someone who has a lot of experience with this procedure and someone who knows exactly where that cannula is. And preferably, you probably want to go to someone that uses the ultrasound to make sure that they're in the right place, okay? Of course, you guys know this. I don't have to really mention it, but no mortalities here at Pure Plastic Surgery, okay? All right, so that is the kind of the end of the year wrap up in terms of the BBL. BBL is what I get asked the most. Maybe if for next year somebody wants me to talk about end of year wrap up for other procedures, just let me know, and I'll be happy to do that. I'm happy to talk about anything you guys want me to talk about. Okay, so now we get to do what we love to do, which is really why Hump Day exists. And of course, I wouldn't end the year without answering your questions, okay? So I'm sure there's a few maybe kind of accumulated there, right?
Yes, we have.
All right, let's get to it.
So let's go back to fat retention. Why is your fat retention better than the national average? Are you doing anything different?
So like I said, so there are multiple techniques, different people do different things. I think one of the things that you want to try to avoid is creating, too much tension. So there's always a give and take, right? So the skin, as you know, is a spring, and that skin is going to stretch to a certain amount, and then it's just not going to stretch anymore. Okay, once it gets to that point, it doesn't really accept that much fat. But if someone, just really tries to push it, and they keep trying to push it in, and create a lot of tension, that's actually a bad thing, because now you have so much tension, that means that you're actually decreasing the blood supply to the area, okay, because it's under so much pressure, all right? And if you decrease the blood supply to the area, therefore less oxygen, okay, less blood flow, less oxygen, less nutrients, less chance of survival for that fat, so that fat gets, reabsorbed. Or the other thing that can happen is that it becomes a scar ball, which we call fat necrosis, okay? So I never like to put things in extreme tension, okay? In terms of how I prepare the fat, that's actually very, very simple. I do just gravity, and then remove, of course, the tumescent or excess fluid, and then we put in the antibiotics into the fat, and then we do the fat transfer. Now, some people ask about PRP. I don't think, honestly, I haven't really seen any study out there to demonstrate that PRP increases fat survival for a BBL, so meaning large volume fat transfer. I'm not talking about small volume, like 3 or 4 cc's, like for example to the face, which is completely different. It's a whole different animal. Large volume fat transfer, I don't think PRP makes a difference. But one of the things we do is that, because we just let it settle out by gravity, okay, that PRP is in your blood, right? When we do the suction, we're sucking out fat, we're sucking out tumescent fluid, but we're sucking out blood, right? So that PRP is pretty much already in there, and we don't spin down the fat and purify the fat. So I think some of those factors that are in your blood are with the fat when we do it this way, and I think that potentially helps as well.
Thank you very much. This next question is about BMIs as pertaining to BBL surgery. What's the optimal BMI that you say you see with patients that works best? Is it?
Yeah, so that's a great question, and actually I've been kind of adjusting it a little bit, as I do more and more BBLs and the practice matures. So say maybe, 2 years ago, I was saying that the most ideal BMI was 28. I think that's probably still a little bit on the high side. I'm kind of adjusting that now. I think probably not the most ideal BMI is probably closer actually to about 25 or 26. I think that's where you really get the best results. And the other thing that that I'm really talking about more now is skin quality. I think skin quality is a huge factor in how well you do with the BBL, especially of course with the liposuction aspect of it. So people with poor skin quality who've had, say, multiple pregnancies, massive weight loss, a lot of stretch marks, a lot of sun, or older patients, fluctuations in weight, all these factors, they decrease skin elasticity. The skin quality is not as good, and therefore it's not able to bounce back as well. And therefore you can have incomplete skin retraction, you can have uneven skin retraction, which can deter from the result. And typically the solution then is not further lipo, because that's not addressing the issue. The issue is a problem with skin laxity, and therefore the way to address that issue is with some sort of skin tightening procedure, which can be something like body tight, if it's kind of on the minor side, to perhaps a mini tummy tuck, or even a regular kind of full tummy tuck is sometimes needed.
Thank you. We know you're very safe, but and you will not combine a lot of procedures with the BBL. Can you just say if there's any procedure that you can combine with the BBL, even chin lipo? Would you combine Botox or filler? Can you do thigh lipo, or what will you be willing to combine with?
All right. So probably the easiest way to kind of think about this is kind of separating out, what I call a surgical procedure versus, say, a suction/transfer procedure. Okay. All right. But so in terms of combinations, if you're in the same category, you can typically combine them. All right. So for example, a liposuction, of course, is a suction procedure, and a BBL is a suction plus transfer procedure. So other suction procedures can be added. So chin lipo can be added, arm lipo, inner thigh lipo, those can be added. Also, some of the non-invasive or minimally invasive skin tightening procedures can be added, such as body tight. Other places have J-plasma. We use the body tight here, but those can be added. And those don't detract from the rules that are here in Florida about the 4 liters, which you've heard me talk about multiple times. So if you keep it all within this one category, then you're good to go with your 4 liters, and you can max that patient out. Okay. And then on the other side is your surgical procedure. So breast augmentation, breast lift, tummy tuck, arm lift, etc. Those, to a certain degree, you can combine. For example, in My Makeover, the most common thing is a breast procedure with a tummy tuck. Very, very common. Sometimes we do what we call the trifecta perfecta, which is the My Makeover plus an arm lift. So with an arm lift, breast lift, plus minus implants, and a tummy tuck, that can all be combined in one procedure. When you do a surgical procedure and you want to do some liposuction, then we're limited to only 1 liter of fat removal by the Department of Health here in Florida.
Thank you very much. Dr. Earle, do you have any experience?
Oh, wait, hold on. Hold on.
Okay.
Because one important. Now, the one thing that we have that we're really excited about, okay, where we are actually taking from both sides, okay, is your Miami Makeover. All right. So in your Miami Makeover, that's going to be a combination of, say, a breast augmentation and liposuction, typically a HD high-def liposuction, okay? So you may be asking like, whoa, hey, Dr. Earle, hold on a minute. How come you can do that? Well, because it's only for very, very specific patients. You have to qualify for that. And one of the qualifications is actually for patients a little bit on the lower BMI side, okay? Because in order for HD lipo to work, the patient has to be in the BMI, a lower BMI, say anywhere between 20 to maybe 24, but not much more than that, okay? And so when we're doing that, then we're getting to that 1 liter really makes a difference, because then it's not about fat removal, but it's really about the etching, okay? It's about creating that definition, creating that beautiful athletic look, okay? So the one kind of case or procedure that we do, where we're taking a little bit from here, a little bit from here, is that Miami Makeover.
Thank you. Do you have any experience correcting paradoxical adipose hyperplasia as a result of cool sculpting?
I don't. So I have of course heard of it. So what it is basically cool sculpt is supposed to basically freeze fat cells and kill them, and then your body absorbs them. But sometimes what happens is actually quite the opposite. So the freeze process you can think of it, kind of shocks the fat cells, and the fat cells actually get bigger instead of smaller. And that's why they call it paradoxical, because you were supposed to kill them, but you didn't, and you made them bigger. I don't have, but honestly, I don't have any experience treating that, and I'm not quite sure if that can just be treated with liposuction or require something more in depth.
So if you have a patient that needs to gain weight, or that you say that should probably gain weight before their BBL,
Yeah.
and this weight that's gained is dispersed all over their body, how does that work if they just want the weight to go to their stomach and then back to the butt?
Right, so that's a great question. So, and it's a good question because sometimes there's a lot of confusion about it, even from other doctors or other surgeons. So there are surgeons out there that say, that's ridiculous. Why would you ask your patient to gain weight? It makes no sense. And I don't agree with that whatsoever. I do think that if you're on the lower BMI side and you want to have a more dramatic result, then you should gain weight. Okay. All right. So why is it even controversial? Well, because it is true that once you're an adult, okay, the number of fat cells that you have in your body is pretty much stable. Yeah, it may shift a little bit, but for the most part, it's stable, okay? But not the size, okay? Not the size. So someone that has a lower BMI may have a similar number of fat cells, but they're just smaller. And if you gain weight, those fat cells become larger, okay? Mm-hmm. And once you remove a certain number of fat cells from an area, the number of fat cells will permanently be decreased in that area, okay? All right, so why does it make sense? Well, it makes sense because it's easier to liposuction bigger fat cells, right? It just makes sense, right? If you're trying to catch a big ball versus a small ball, it's easier to catch a big ball, okay? So it's easier to liposuction larger fat cells than it is smaller fat cells. And then you're gonna be transferring those fat cells to a different area of the body, and which then a significant portion of them will survive, okay? So you permanently decrease the number of fat cells in a certain area, say for example the waist, and you've permanently increased the number of fat cells in another portion of the area, say for example the hips, which could never happen any other way unless you actually do a fat transfer. It's almost like you can think of it like a fat transplant, which is exactly what it is, okay? All right, so if you then, lose weight after the procedure, then of course all the fat cells will shrink wherever you put them, okay? So if your waist was this small and you lost weight, then you'll probably lose a bit more in the waist. But then if your hips were like this and you lost weight, you may lose some of the hips as well. But the proportion after surgery will remain the same. The waist will always will be smaller than the hip, okay? And that's why we can dramatically alter shapes with this procedure. That's the power of the BBL or the fat transfer procedure. You can dramatically alter a patient's shape permanently, basically, for the rest of their lives, okay? And that is not something that you can do in the gym. You always get these people and they're like, she should have done squats. And it's ridiculous because you can't round out hips with squats. It's physically impossible to do. And actually, if you lose weight and you lose more fat cells in the hip area, have you seen runners? Have you seen people? They actually dip more because you lost all that fat. What creates the roundness of hip is fat, it's not muscle. Okay? Yeah, projection maybe muscle can do some projection, but they're not going to create nice, beautiful round hips and curves. Okay? So for that, you need fat transfer.
What is the difference between a board-certified cosmetic surgeon and a board-certified plastic surgeon?
There's a very big difference, okay? There's a very big difference, and it has to do with your training, okay? And how strenuous your training is, okay? So actually, the Board of Cosmetic Surgery is not a board that's recognized by the American Boards of Medical Specialties, ABMS, okay? So it's not a recognized board, and it's not a recognized board because the hoops that you have to jump through to get that are not as rigorous or strenuous as those that you have to jump through to become a board certified plastic surgeon. Of course, the American Board of Plastic Surgery is a board that is approved by the American Boards of Medical Specialties. Okay, so in order to become a board certified plastic surgeon, you have to do a residency that is specific to plastic surgery. Okay, which is typically the shortest ones are typically 6 years. That's 6 years after graduating from medical school. Okay, so 6 years after graduating from medical school. Once you've done that, then you have to take a very rigorous and not fun exam, a written exam, okay? And you gotta pass that written exam. And then you gotta be in practice for about a year. You got to accumulate a certain number of cases, and you got to make sure that you're a safe plastic surgeon, okay, before you're even allowed to sit for the oral boards, okay? And then you do another very not fun, rigorous oral examination where you also have to present your cases, okay? And once you do all of that, then and only then can you become a board certified plastic surgeon, okay? And of course, it's not just, when you do that as a board certified plastic surgeon, it's not just about aesthetics, right? It's not just about cosmetic, it's about the entire world of plastic surgery, which is actually much, much bigger than, you know, what we're doing here now. It's some of the stuff that I used to do. When I was in Cleveland Clinic for 5 years as a staff member doing reconstructive surgery. So it's about, you know, breast reconstruction, abdominal wall reconstruction, free flaps, you know, facial reconstruction after cancer or skin cancers, all these things that plastic surgeons do, burns, treating burns. I mean, plastic surgery is very, very broad, and cosmetic surgery is a part of that, okay? But we get a lot of general surgery training, we get a lot of ICU training, we get a lot of patient care training. It's very, very rigorous, very, very intense. And that's different for cosmetic surgeon. They can come from any background, okay? They can be a dentist, they can be, you know, a general, you know, just a general surgeon. You know, they don't necessarily have to do any training specifically in plastic surgery, okay? And then after that, some, you know, will do, you know, a cosmetic surgery, say fellowship for like a year or so. And then after that, you know, they can get the cosmetic board.
Thank you very much. Do you like wish pics from your patients?
Yes and no. I don't. So the no is because a lot of times the wish pics are not realistic, and so the patient has this idea in their mind of how they think they want to look or how they want to look, and a lot of the times it's not achievable. And the problem is, and I don't know, and I'm working on this because maybe sometimes it's my communication, maybe I'm just not blunt enough. I don't like hurting people's feelings. But sometimes, even though I try to tell them that, you know, explain to them that's not really achievable, or tell them that their foundation is very challenging, or things of that nature, you know, that wish pic doesn't leave the mind, and so when the surgery is done and they don't look at the wish pic, you know, sometimes they get upset.
Okay.
On the other side, though, if you have what I call an appropriate wish pic, meaning if you're either maybe like slightly photoshopping a picture of yourself, nothing exaggerated, but, you know, slightly doing that, or if you chose someone with a before photo that looks very similar to you before, those are a bit more helpful. The other way that they're helpful is because it does give me an idea of kind of like what overall shapes you like. So it's not, we don't do cookie cutter type surgery here. So you could, if you scroll down my IG, you see, like, you know, for example, recently we have someone who had, you know, fair amount of hips and projection. And then if you keep scrolling down, you see someone who has a very, very natural, more athletic result. There's no cookie cutter surgery here. And I don't know that I particularly have one style that everybody comes out looking the same. I don't think so. I try to tailor my surgeries to each individual patient. I do have favorite styles though, and I think you guys know that. I love that upside down heart shape booty, and that's kind of one of my go-to styles. So on the downside, I don't like wish pics because a lot of times they bring about unrealistic expectations, which only lead to patients not being happy in the end. On the upside, if you have the appropriate picture, it does give me an idea of what you're looking for, and I can tailor my surgery to that to try to get you as close to that as possible. But having said everything, all that, you know what I do like though? Even though sometimes they're not realistic, I like the vision boards. I do. I love it when the patients come in and I can see they spend a lot of time on their vision board. It just shows their creativity, and also I like to take it with me and put it up in the OR, and, you know, it just gives me kind of an idea of what the patient's looking for, and I always try to do my best to get as close as I can. I mean, sometimes anatomy doesn't let me achieve specifically what's on the board, but I always do my best to try to get there. And so I think the vision boards are pretty cool.
During a liposuction procedure, can you take fat from the back with a hidden incision under the arms instead of the incision in the middle of the back? I'm worried about the obvious scar when I wear backless dress.
So, I mean, is it possible? It's possible. It's not my go-to incision, as you guys know. I try to put it along that bra line. So if you are wearing a swimsuit it's kind of covered there. Yeah, you're right. If you're wearing a completely, no back at all, it potentially could show. That would be something that's very, very specific that I would have to talk to that patient individually. We discuss the pros and cons of doing so. I just think it provides the best access, which is of course why we do it. So I like that incision because it provides the best access to the kind of mid to upper back, and to try to get as much of that fat out in that area, which is overall a more difficult area to address because the skin in that area is very, very thick and the fat tends to be very fibrous. So it's fat that doesn't come out easily through the cannula. It's an area that you really have to work hard to try to reduce. And then the other thing that, now that you've touched upon that subject, while you can reduce a lot of the fat in the area, it's very hard to make somebody's back less wide, okay? And that's because it's not just fat that makes a back, a certain width. For example, one of the things is of course your shoulder width, and that's not something that we can change with liposuction. And the other thing is your muscles. We call your latissimus muscle, which is some people in layman's terms think of it as that swimmer's muscle. So that latissimus muscle, of course, we can't change with liposuction either. So very, very tough. If someone comes in and they're like, I want my back to be less wide, it's really tough to do that because you have those shoulders, you have those muscles. So yeah, you can reduce the fat overlying those structures, but you can't reduce the underlying structures themselves.
I know you can talk about this for hours, but briefly, can you just explain what do the breast implant sizes mean, and like high profile, low profile, 325? What do these numbers mean? And
yeah, so
really briefly, if you can.
So in a nutshell, implants, they come in multiple different sizes and multiple different profiles and also different shapes. Now, regarding the shapes here, pretty much I almost exclusively use the smooth round implants. As we know, we've been learning textured implants you don't want to use textured implants nowadays because they've been related with a lymphoma. So I stay away from any textured implant really. So I use a smooth round implant, okay? And there's a few profiles. There's low, moderate, high, and extra high. Or low, moderate, full, and extra full. And so the profile tells you how much the implant kind of projects out towards the front. And so in terms of what it looks like in a patient, they're going to have more projection towards the front, but also provides more fullness in that upper pole. So as the profile goes up, it is more of I guess you would call it like a surgical look, or more of a fake, you can call it a fake look, but basically the implant is much more noticeable the higher up you go in profile. So if you want more of a natural look or a natural shape, you'll probably stick around with the moderate profile implants. If you want that really kind of top high look, you're going to be going into like the full or extra full type of implant. But of course then there's different sizes. So what the numbers mean is volume, so cc's, okay? So the size of the implant depends a lot on your measurements. So a lot of times that's why I can't tell you just by looking at a photo, what size implant you should have. We determine that here in pre-op. I'm going to take all your objective measurements, and based on those measurements, then we can choose an implant that's probably the most appropriate size for you, okay? Because you don't want an implant that's too big for somebody's frame. That's just going to cause problems in the future.
Thank you. Should a person take collagen to help with skin elasticity, or do you have any recommendation to help with skin elasticity?
So I don't really have a lot of data showing whether collagen helps it or not. And unfortunately, but a lot of times by the time the patient gets to us, the things that you could have done have unfortunately already happened. So if you're young and you haven't gone through these things yet, then what I do recommend, of course, is certainly no smoking. Don't ever smoke ever, because smoking will ruin skin elasticity for the rest of your life. And also minimize sun damage. Okay, so UV sun damage will also affect your skin elasticity. And try to stay in shape and maintain a healthy weight throughout your life. So fluctuations in weight will stretch out the skin, and every time skin stretches out, it doesn't bounce back as well. That's why pregnancy is such an issue. Okay, so if you can not smoke, not get sun, maintain a healthy weight, that's going to go a long way. Okay, And then the other one, I mean, I'm not going to tell people not to get pregnant. That's kind of ridiculous. So that's just something you just have to accept, basically.
Can you fix my lipo irregularity during my BBL? I'm 22 with good skin laxity.
So if you're young and you have good skin elasticity, then yes, that should be able to be improved with potentially a second round.
Can you do a mini tummy tuck with a BBL?
Yeah, usually don't do that with a BBL for the similar reasons we discussed just a few minutes ago. So I like to separate things out. So since we're on that topic, so if I see someone and I feel like they don't have great skin elasticity, I'll tell them, like, today we're going to focus on your BBL. And we're going to see how your skin does, and of course a lot of it has to do with your post-op care, mainly the way you're compressing and your massage therapist. But if this skin does not retract completely or doesn't retract evenly, then you will need a skin tightening procedure in the future, and that's going to have to be at a second stage with either the mini tummy or the tummy tuck. What's the soonest that it can be done? It will be about 3 to 4 months after your BBL.
I have lost 112 pounds and lost absolutely everything, including my butt. What do you recommend first, the lipo and then the mommy makeover, or?
So that's going to depend on how loose that skin is after 112 pound loss. So it's hard to kind of make a decision without actually evaluating you. So that's why you want to send all your information, your photos, through our virtual consultation system. And then once I'm able to evaluate all that, I can make you a more informed decision as to which one to do first. But it really has to do with how much hanging skin there is. So there's a lot of loose hanging skin, then typically it's best to address the skin issue first. And then therefore you would start with your mommy makeover. If the skin, if we know the skin's gonna need a procedure later, but it's not like so overhanging, then in those cases sometimes you can start with a BBL first.
Thank you very much. Next question is, do you use a breathing tube?
Yes, we do. So remember, pretty much all surgeries here at Pure are under general anesthesia. Okay, so when you use general anesthesia, that means that you do require that breathing tube. Okay, and you're hooked up to the ventilator during your surgery.
Thank you. So how do you determine? The question is, if I get a BBL first instead of a mommy makeover first, will that change the price that I was quoted? Both surgeries, if I'm doing both surgeries with you, how would you recommend what's first? Or is it cookie cutter, or is every patient different?
So we take a lot of consideration for our patients, meaning if you had a procedure with us and you're coming back to us, we think that should be something that's rewarded, basically. Mm-hmm. We love our patients and we love them more when they come back. And so we're I think we're the first. I don't know, I haven't heard this from anybody else. But I think we are the first clinic to have what we call the Pure Loyalty Rewards member program. Mm-hmm. Okay? There's a lot of details regarding this in the Facebook group. So if you're a part of that, you can look it up under the announcements. Okay, but if you've had a procedure with us and you're happy and you've demonstrated how happy you are and you want to come back to us, we're gonna reward that. We're gonna greatly, we're gonna grandfather in your prices. We're gonna greatly discount your prices. There's gonna be a lot of special considerations for our beautiful pearls that come back to us.
How can we maintain the fat in the hips after a BBL?
So the main thing is really you want to avoid pressure. Okay, I know this is also something that maybe different surgeons have different specifications for, but for me, you want to minimize any pressure to the buttock or hips for the first 6 weeks. Okay, so that's really so the one thing is minimize the pressure, and then the second thing is feed the fat. Okay, so what is feed the fat? You want to have a diet high in healthy fats after your BBL. What are healthy fats? So avocado, salmon, or the fish with the high omega-3 fatty acids, certain nuts like macadamia nuts, and then of course actually what really helps is also some milk products such as ice cream and milkshakes. All right, and Boost can help as well. But the key is that you want to feed the fat in those first 6 weeks. You definitely do not want to be losing any weight in the first 6 weeks. That's not good. It's detrimental. So you want to feed the fat. You want to, at the very least, maintain the weight that you came in with at surgery. So maintain your surgical weight, or perhaps even increase it just a little bit, say 5 pounds or something, up to 5 pounds. I don't want you to go crazy. Don't gain 30 pounds after surgery. That's not good either, okay? All right, but if you at the very least maintain your weight or gain, say perhaps 5 pounds, that especially in those first 6 weeks to 3 months, that's what's gonna give that fat the best chance of survival.
Thank you. We know there are a lot of surgeons who are board certified in plastic surgery, but you are board certified in general surgery and plastic surgery. How do you maintain both certifications?
Yeah, so that's because of the way that, or the route that I took, which, I don't know if you can see it in my face, but I'm a little bit older, okay? But that's the way that it actually used to be. So, previously when we were talking about that, I said that the fastest kind of route was to do a plastic surgery residency, which is 6 years. That's today. Today you can graduate from med school and get into a plastics residency, and in 6 years you can basically graduate. But that's not the way it used to be. Back when I did it, you had to do general surgery first, and then do plastic surgery. And so general surgery was 5 years, and plastic surgery for me was 3 years. Okay, so a total of 8 years. So in terms of my training, I trained forever, guys. I did 5 years of general surgery. I did 2 years of NIH research, and then I did my 3 years of plastic surgery training. Okay, so essentially it took me 10 years to be able to graduate as a plastic surgeon. But because of the way I did that, I was able to get my board certification in general surgery and my board certification in plastic surgery. So I am a double board certified plastic surgeon. And then you got to maintain those certifications, which actually I did my general surgery one this year. So another thing that's changed. So back in the day, once you got board certified, you're board certified for life, which is pretty cool, but not for us. For us, your board certification can expire, and typically they give it about 10 years. So within those 10 years, you have to do what's called CME, Continuous Medical Education. And at the end of those 10 years, you got to take another exam, another very painful written examination. And so this year, 2020 actually was my year to coming up for general surgery. So I did that. I had done all my CMEs, and I took my written examination and passed it. So, I will continue to be a board certified general surgeon for the next 10 years. And then I believe maybe in 2 years or so, I'm gonna have to do all that for my plastic surgery board certification.
All right, so we're well over 40 minutes. I know you have to go soon for our last live of 2020, but let's just knock out a few more questions.
Yeah, let's do it. It's the last one. 20's coming to a wrap.
Yes.
It's been a crazy year, guys.
Right.
This whole COVID thing and everything else. That's something we're really proud of as well. I mean, we've done super well with our COVID protocols. We've had, it's been a full year of that, and we've had no issues. We're extremely happy with it. But yeah, it's been quite the year.
Can ab etching be added the day of surgery?
It can, yeah. It can be added the day of surgery. And like I said, not everyone qualifies for that. Not everyone qualifies for ab etching or HD or high def lipo. Okay, so there's got to be a few qualifications. One is the BMI can't be too high, so typically 24 or less. And 2 is the skin quality has to be good. So you have to have good skin quality and not too much fat for ab etching or HD lipo.
Thank you very much. How many weeks post-op can patients start traveling internationally? It's a 14-hour flight, is really the question.
So the minimum stay just in general is 5 days post-op. Okay, but if you're going on a very long flight, say coming from London or Europe, we have patients from London. We have patients from not international, but from Hawaii. We had even patients from the Netherlands. So for those patients, if they can, I would recommend staying longer, at least 10 days, okay, before flying back home. So the risk of Dvts and Ps after surgery is highest in the first 2 weeks, okay? But it gets down to a point that's low enough where all the experts say that it's okay to travel, kind of not locally, but within the US, by post-op day 5. But if you're going on a very long transatlantic flight, then you probably want to wait, just a bit longer, maybe about 10 days or so. And certainly for any flight that's over 3 hours, you should have a sequential compression device, such as the Circulate, which is the one that we have here. So we highly, highly recommend the Circulate for anyone who's having surgery and then has to fly over 3 hours. So all those patients should have the Circulate. And then certain procedures are known to have a little bit higher risk for Dvts and PEs, which are mainly tummy tucks and mommy makeovers, because it includes a tummy tuck. And so for those patients, regardless of how long their flight is, they should have a Circulate as well.
Thank you very much.